Welcome, curious minds, to another deep dive. Today, we're plunging into something so fundamental, so automatic that we rarely give it a second thought. Breathing. Every single second, our bodies perform this incredible feat, effortlessly drawing air in and pushing it out. But what truly goes on behind the scenes with every single inhale and exhale? How is that air prepared for your delicate lungs? How does your body make sure it gets enough oxygen? And just as critically, how does it get rid of the carbon dioxide that builds up, all while maintaining the body's delicate pH balance? It's an extraordinary feat of biological engineering happening within you right now. For this deep dive, our sources come from a highly detailed medical text, offering a foundational understanding of the human respiratory system. Our mission today isn't to turn you into a medical expert, but to cut through the density, pull out the most important, fascinating insights, and help you become genuinely well informed on this vital system and its implications, especially when things aren't working quite right. This isn't just about the simple act of breathing, it's about the body's exquisite balance, its surprising resilience, and how modern medicine steps in when that balance is threatened. So, let's unpack this incredible system piece by piece to truly appreciate what's happening with every single breath you take.
It's true. While its primary goal is simple gas exchange, the respiratory system is a marvel of multifunctional design. It does far more than just bring oxygen in and push carbon dioxide out. It's crucial for maintaining the body's pH balance, allowing us to vocalize and speak, and providing a robust defense system to filter and protect against airborne invaders. It even plays a role in the body's metabolism.
It's definitely more than just a pair of bellows. So, what are the main components working together in this incredible symphony?
Imagine an integrated network. You have the conducting airways, which are essentially the pipes carrying air deep into the body. Then there are the lungs themselves with their intricate blood supply, where the actual oxygen and carbon dioxide swap takes place. Your central nervous system contains the control centers that orchestrate everything, instructing the muscles of your chest wall and diaphragm that physically move air in and out. All these parts work in concert, ensuring you keep breathing efficiently, minute by minute, day by day.
Let's start right at the very beginning of the journey. Your nose. We often take it for granted, but it's really quite sophisticated, isn't it?
Absolutely. The very entrance to your respiratory system, your nostrils, are supported by flexible cartilage that allows them to flare. Inside the vestibule, the front part of your nasal cavity is lined with coarse hairs. Think of these hairs as your primary filter, trapping larger particles before they can even go deeper.
So, an immediate bouncer for incoming air, and the rest of the nasal cavity is equally busy.
It truly is. The inner lining of your nasal cavity is quite special. The upper part is dedicated to smell, sensing the world around you. But the much larger lower portion is lined with specialized cells that continuously produce mucus. This mucus acts like flypaper, trapping smaller particles that made it past the initial hairs. Crucially, these cells also have tiny, hair-like projections called cilia that constantly sweep this mucus along with any trapped debris, either towards the front of your nose to be expelled or towards the back of your throat to be swallowed. It's a continuous, self-cleaning defense mechanism. This part of your nose also warms and humidifies the air before it enters your lungs, protecting the delicate lung tissue.
So it's constantly cleaning itself, sensing and conditioning the air. That's incredible, and understanding this matters in a practical sense, too.
Definitely. For instance, when medical professionals need to insert a breathing tube through the nose, knowing the precise anatomy ensures the tube goes safely into the airway without damaging those delicate internal structures. It also highlights why any infection that starts in the nose, if severe enough, can have more serious implications because of how connected the facial structures are.
Right. From the nose, we move deeper into the pharynx, which sounds like a very busy intersection for air and food.
It is indeed. The pharynx is a wide, muscular tube that serves as a common passageway for both the air you breathe and the food you eat. It extends from the back of your skull down to a point where your windpipe and food pipe diverge. This area is a common spot where foreign objects, like a small toy or a piece of food, can accidentally get stuck. The pharynx is conceptually divided into three main sections. The nasopharynx, located behind your nasal cavity, the oropharynx, which is behind your mouth, and the hypopharynx, which is the lowest part, leading down to your voice box and esophagus. It's a literal crossroads where the body has to make a critical decision with every swallow.
And then we reach the larynx, which most of us think of as just our voice box, but it's much more than that, isn't it?
It absolutely is. While it's commonly known as the voice box, its primary role, from an evolutionary perspective, is actually protective. Think of the larynx as the guardian of your airway, dedicated to preventing anything from entering your windpipe except for air. Vocalization evolved secondarily, The larynx itself is quite intricate, made up of a unique bone and several important cartilages, all connected by ligaments and muscles.
A unique bone.
Yes, the hyoid bone. It's particularly fascinating because it's the only bone in your body that doesn't directly connect to another bone. It's suspended, supporting the larynx. The main structural framework comes from two key cartilages: the thyroid cartilage, which forms the prominent Adam's apple, and the cricoid cartilage. Now, the cricoid is important. It's a complete ring of cartilage that encircles your airway, marking the very beginning of your windpipe.
Ah, the only complete ring, right.
Exactly. And then there's also the epiglottis, a crucial leaf-shaped cartilage positioned near the root of your tongue. This acts like a trapdoor. During swallowing, your larynx elevates, causing the epiglottis to snap shut, effectively sealing off your windpipe and directing food or liquid into your esophagus. This prevents aspiration, which is, a major concern in medicine.
So a brilliant piece of biological engineering, acting as both a gatekeeper and an instrument, finely tuned for protection and communication.
Precisely. And internally, the larynx has different compartments. Your true vocal cords are the ones that vibrate to produce sound, attached anteriorly to the thyroid cartilage. Their precise movements, driven by tiny muscles and the rotation of small arytenoid cartilages that sit atop the cricoid, allow for a vast range of vocalizations. Some muscles open the vocal cords for breathing, while others close them for speaking or to protect the airway. Other muscles lengthen or shorten the cords, adjusting their tension to control the pitch of your voice. It's an incredibly coordinated system that not only safeguards your lungs, but also enables the complex act of human speech.
It's incredible how much fine-tuning is involved just in producing sound. And all this is controlled by very specific nerves, right?
Yes, the larynx relies on branches of the vagus nerve, one of your cranial nerves, for both sensation and movement. One branch, the superior laryngeal nerve, provides sensation to the upper part of the voice box and helps control the cricothyroid muscles, which are key for adjusting vocal cord tension and thus your pitch. If this nerve is damaged, your voice might become weak or easily fatigued.
Okay.
Another critical branch is the recurrent laryngeal nerve. This nerve has a particularly circuitous route. The one on the left side actually loops all the way around the arch of your aorta near your heart before traveling back up to the larynx. Both recurrent laryngeal nerves control nearly all the muscles responsible for opening and closing your vocal cords.
So their long, winding path makes them vulnerable.
Exactly. Due to their long and unique paths, these recurrent laryngeal nerves can be vulnerable to injury during neck surgery, certain medical procedures, or even from tumors in the chest, leading to vocal cord paralysis. This can cause hoarseness, or, if both nerves are affected, severe breathing difficulties, highlighting just how critical these nerve pathways are.
Wow. Moving past the larynx, we get to the windpipe, the trachea. What's its most surprising feature?
One of the most surprising things about your trachea is that it's not as rigid as you might think.
Oh.
While it's supported by C-shaped cartilage rings that keep it from collapsing, it's actually quite flexible, expanding and contracting with head and neck movements. This is a crucial detail for patient care. For instance, if a patient has a breathing tube inserted into their trachea and they then flex their neck, the tube can actually move deeper into the lungs.
Oh, right into one lung, potentially.
Potentially, yes, ending up in only one lung, which is called an endobronchial intubation. Conversely, if they extend their neck, the tube can move upward, increasing the risk of accidentally coming out entirely. So even a slight head movement can drastically shift an endotracheal tube, a critical detail that medical teams must constantly monitor to ensure proper breathing.
So fascinating how something seemingly simple can have such big implications. And speaking of branching, let's talk about the bronchi and those fascinating bronchopulmonary segments.
After the trachea, you reach a point called the carina, where it elegantly divides into the right and left main bronchi, heading into each lung. The way they branch is slightly different but very important. The right bronchus takes a straighter, wider path, almost like a direct highway into the right lung. The left bronchus has a more acute angle and is a bit longer.
And why is that difference so critical?
Well, that subtle anatomical difference is critical because if you accidentally inhale something, a small piece of food, or a breathing tube goes a bit too far, it's far more likely to go down that straighter, wider right bronchus. It's why understanding these differences directly impacts everything from how medical procedures are performed to how foreign objects are handled in the airway. And from there, these main bronchi continue to branch, like an intricate tree getting progressively smaller.
So like a tree, it keeps dividing and reaching every corner of the lung.
Precisely. These branches continue to divide, ultimately leading to tiny, distinct regions within your lungs called bronchopulmonary segments. Think of these as individual, self-contained functional rooms or units within your lungs, each served by its own dedicated air tube. If there's an issue like an infection or inflammation in one of these segments, it often remains isolated there. This segmented design is quite remarkable, allowing for localized problems without affecting the entire lung.
It's an incredibly organized tree, right down to the segmented rooms of the lung. And then, surrounding all of this are the lungs themselves and the pleura.
The lungs are truly extraordinary organs, and they're encased by a specialized double-layered membrane called the pleura. Imagine this as a delicate, slippery sac that lines your chest wall on one side and covers the surface of your lungs on the other. Between these two layers is the pleural cavity, a potential space that normally contains just a tiny bit of lubricating fluid.
And that's where that crucial slippery space comes in.
Exactly. That slippery space between your lungs and chest wall is like a perfectly sealed vacuum. The negative pressure within this space acts like a suction cup, keeping your lungs fully inflated and allowing them to slide smoothly against the chest wall as you breathe. When that seal breaks or if fluid or air accumulates in that potential space, things get serious fast because it can prevent the lung from expanding properly.
Right, like a collapsed lung.
Exactly. For example, a pneumothorax is when air leaks into that space, causing part or all of the lung to collapse. A tension pneumothorax is even more dangerous. Air gets trapped and builds up pressure, which can actually push your heart and other lung to the side, dangerously compressing them. You can also get hemothorax, which is blood in that space, or pleural effusion, which is a buildup of clear fluid. Each of these compromises normal lung expansion and ventilation, making it incredibly difficult to breathe.
And all of this is centrally located in the mediastinum.
The mediastinum is the central region of your chest, nestles between your two lungs. It's where your heart, great blood vessels, trachea, and esophagus are all located. It's slightly displaced to the left by the heart, which is why your left lung is a bit smaller than your right. This area is critically important because if structures within it, like your windpipe or food pipe, are injured or perforated, it can lead to a severe and life-threatening infection of this central hub.
Now let's talk about the engines of breath, the muscles of respiration. For normal, quiet breathing, it's mostly two key players, right?
Primarily, yes. During quiet breathing, the diaphragm is the main muscle. It's a large, dome-shaped muscle located just below your lungs. When it contracts, it flattens and moves downward, effectively increasing the space in your chest cavity and pulling air into your lungs. Normally, it only moves a tiny bit, maybe a centimeter or two, but with forceful breathing, it can move much more, up to 10 centimeters, drawing in a lot more air.
Wow, quite a difference.
It is. And the diaphragm is powered by nerves that come from the upper part of your spinal cord, specifically C3, 4, and 5, which is why we have the memorable phrase, C3, 4, and 5 keep the diaphragm alive. The external intercostal muscles, located between your ribs, also help by lifting your ribs and sternum, further expanding your chest.
And why is the diaphragm so singularly effective?
That's a great question. Its unique structure, particularly its central tendon, provides a kind of rigid point. This allows it to flatten and create powerful pressure changes without pulling against external insertions, making it incredibly efficient. Also, each half of the diaphragm actually functions independently, powered by its own nerve. So if one serrated nerve is injured, only that half, or hemidiaphragm, is paralyzed. This leads to what's called paradoxic movement. The paralyzed side moves upward when the functional side contracts downward during breathing. It really highlights how crucial proper diaphragm function is. Spinal cord injuries above C5 usually mean mechanical ventilation is needed.
So fascinating how one muscle can be so pivotal. Now let's discuss lung compliance and elastic recoil. It's like a balloon. Some are easy to blow up but sag quickly. Others are stiff but hold their shape. Your lungs have this delicate balance between being pliable and having enough snap to push air out.
That's a perfect analogy. Compliance is essentially a measure of how stiff or stretchy your lungs are, how much effort it takes to expand them. Lungs with low compliance are stiff and hard to inflate, like trying to blow up a thick new balloon. This can happen with conditions like fibrosis, where lung tissue becomes scarred and stiff, or even just significant obesity compressing the chest. On the other hand, lungs with high compliance are very distensible and easy to inflate, like a very old stretched-out balloon. This is seen in conditions like emphysema, where the elastic tissue of the lung is destroyed. So it's easy to get air in, but then it's difficult to get it back out because there's not enough snap or elastic recoil to push the air out.
And that elastic recoil is key for exhaling, right?
Exactly. Elastic recoil is that snap you mentioned, the natural tendency of the lungs to return to their resting state after being stretched. This force, along with the surface tension and the fluid lining your tiny air sacs, plays a major role in passively pushing air out during normal, quiet breathing. Understanding this balance is critical because it dictates how efficiently your lungs can fill and empty. We even measure it clinically static compliance when air isn't moving and dynamic compliance during airflow.
It's incredible that we can understand something so nuanced about how our lungs work. And these measurements tie directly into the invisible forces at play, the pressures within the respiratory system.
Yes, understanding these pressures is fundamental to appreciating how breathing works.
Hmm.
First, there's pleural pressure, the pressure in that potential space outside your lungs between the two pleural layers. In a healthy, spontaneously breathing person, this pressure is always negative, or below atmospheric pressure. It's this negative pressure that acts like a suction, pulling your lungs outwards and keeping them expanded. During inspiration, it becomes even more negative to pull air in, and during expiration, it becomes less negative as things relax.
Okay, so negative pressure outside the lung.
Right. Then you have intraalveolar pressure, which is the pressure inside the tiny air sacs themselves. At rest, between breaths, it's equal to the air pressure around you. To get air into your lungs, your diaphragm contracts, expanding the chest, which makes the intraalveolar pressure slightly negative relative to the atmosphere, drawing air in. To push air out, the chest recoils, making it slightly positive, pushing air out.
Got it. And the third one?
Finally, there's transpulmonary pressure. This is the critical difference between the pressure inside your air sacs, intraalveolar, and the pressure in that pleural space, pleural pressure. It's the net pressure that actually distends or stretches your lung tissue. This pressure must always be positive for your lungs to stay inflated. If it drops to zero, as happens when air leaks into the pleural space during a pneumothorax, your lung collapses because it loses that vital distending force.
So managing that pressure is key in intensive care.
Absolutely. This raises an important question. Why is managing transpulmonary pressure so critical in modern intensive care? Because it allows medical teams to precisely control how much stress they're putting on delicate lung tissue, minimizing further injury from things like ventilators. It helps guide settings to keep the lungs open but avoid overstretching them.
So it's a direct measure of how inflated the lungs are, regardless of external factors. And as air moves, it encounters resistance, right?
Exactly. Airway resistance describes the obstacles to airflow. But think of it like water flowing through pipes. Some pipes offer more resistance than others. The type of flow, whether it's smooth and orderly laminar or chaotic and swirling turbulent, depends on factors like how fast the air is moving and the diameter of the airway. Turbulent flow tends to happen in larger airways like the trachea. Interestingly, the greatest resistance to airflow normally resides not in the tiniest airways, but in the medium-sized bronchi, where the tone of the smooth muscle plays a key role.
That seems counterintuitive.
It does, doesn't it? While individual tiny airways have high resistance, the net total resistance in the vast network of small airways is actually very low. Why? Because there are so many of them working in parallel, like many small streams joining to form a wide, slow river. The total cross-sectional area is huge. Another interesting point is how lung volume influences resistance. When your lungs are fully inflated, the airways are pulled open, which actually reduces resistance. But during forced expiration, especially in conditions like asthma or COPD, those smaller airways can actually compress and narrow, increasing resistance and making it very difficult to get air out.
Now let's talk about how much air we're actually moving with lung volumes and capacities. We all know we breathe in and out, but there's a lot more to it.
There is. Your tidal volume, VT, is the amount of gas you move in and out. With each quiet breath, about half a liter, maybe 350 to 500 milliliters, typically.
Yeah.
Your minute volume is simply that tidal volume multiplied by how many breaths you take per minute. But not all the air you breathe in actually participates in gas exchange. Some of it just fills the conducting airways, like your trachea and bronchi. This is called anatomic dead space. It's ventilation that simply doesn't reach the air sacs for oxygen or carbon dioxide exchange. About 2 millivalves per kilogram of body weight, roughly.
So a fair amount just fills the pipes.
Pretty much. What matters most for gas exchange is alveolar ventilation. That's the part of your minute volume that actually reaches the air sacs. Beyond that, you have your residual volume, RV, which is the gas left in your lungs after a maximal exhalation. You can't voluntarily remove this. It's usually around 1.2 to 1.5 liters. This residual air is crucial because it contributes to your functional residual capacity, FRC. FRC is the volume of gas remaining in your lungs after a normal quiet breath out. It's the sum of your expiratory reserve volume and residual volume. This FRC is essentially the gas reservoir available for oxygenation between breaths or during pauses in breathing, helping to smooth out your blood oxygen levels.
And the other volume?
You have the expiratory reserve volume, ERV, which is the extra air you can force out after a normal exhale. And the inspiratory reserve volume, IRV, the extra air you can force in after a normal inhale, which is usually quite large, maybe 2.5 to 3 liters. These volumes combine to form capacities. For example, vital capacity, VC, is the maximum amount of air you can move in and out of your lungs in one breath, IRV plus VT plus ERV.
Wow.
Total lung capacity, TLC, is everything, including the residual volume, VC plus RV.
Okay, that makes sense. What about closing volume? You mentioned that earlier.
Right, closing volume, CV, and the related closing capacity, CC, are critical concepts, especially as we age or with certain lung diseases. Closing volume is the point during exhalation, specifically the volume above your residual volume where your very smallest airways start to collapse. Closing capacity is that volume plus the residual volume. Normally, this collapse happens only when your lungs are almost empty, well below the FRC, the amount left after a normal breath. However, closing volume naturally increases with age.
So as you get older, your small airways are more prone to collapsing even during normal breathing.
Precisely. It increases quite a bit, maybe from 30% of your total lung capacity at age 20 to over 50% by age 70. And conditions like lying flat, pregnancy, obesity, or lung diseases like COPD also increase this tendency for early airway closure. The clinical significance is profound. If your closing capacity exceeds your FRC, it means your small airways start to close during normal tidal breathing. Some of your air sacs aren't getting proper ventilation, even though blood is flowing to them. This leads to inefficient gas exchange, called intrapulmonary shunting. It's a sensitive indicator of early small airway disease, like that caused by smoking.
Moving beyond the blueprint, let's get into the core functions, starting with gas exchange in the lungs and revisiting that idea of dead space.
Right. When we talk about gas exchange, a key concept is dead space, which again is ventilation that doesn't participate in gas exchange. We discussed anatomic dead space in your conducting airways, but then there's alveolar dead space. This occurs when your tiny air sacs, the alveoli, are ventilated, they get air, but they're not perfused, meaning there's no blood flow going past them to pick up oxygen or drop off CO2, maybe due to a blockage like a pulmonary embolism, for instance. The sum of these two anatomic and alveolar dead space is your physiologic dead space. We can actually calculate this by comparing the CO2 level in your arteries with the CO2 level in your exhaled breath.
And the actual gas levels in the alveoli are constantly adjusting.
Absolutely. The levels of oxygen and carbon dioxide in your air sacs are a delicate balance, determined by several factors: how fast and deep you're breathing, your alveolar ventilation, the oxygen and carbon dioxide concentrations you're inspiring, how much blood is flowing through your lungs, and your body's overall metabolic rate, how much oxygen it's consuming, and how much CO2 it's producing. Remember, atmospheric air is about 21% oxygen, around 160 millimeter Hg pressure, and very little CO2. As it enters your airways, it gets heated and humidified. The water vapor adds its own pressure, which slightly dilutes the oxygen concentration even before it reaches your lungs, maybe down to 149 millimeter Hg-inspired PO2. Once in the air sacs, that fresh air mixes with the residual air already there, the FRC, and then a rapid swap happens with the blood flowing through your pulmonary capillaries. Your air sac oxygen level, the PO2, ends up being lower than the inspired PO2, maybe around 100 millimeter Hg. Why? Because oxygen is constantly being pulled out into the blood, while CO2 is constantly being added from the blood.
And CO2 levels are inversely related to breathing.
Exactly. The amount of carbon dioxide in your air sacs, the PaCO2, is almost perfectly inversely proportional to how much you're breathing effectively, alveolar ventilation.
Yeah.
If you double your ventilation, you effectively have the PaCO2. Increasing ventilation also brings your alveolar oxygen level slightly closer to the inspired level, but the CO2 relationship is much more direct.
It's a precise give and take, and the lungs even regulate their own blood flow in a unique way with hypoxic pulmonary vasoconstriction.
Yes, this is truly fascinating and unique to the lungs. Unlike most other parts of your body, where low oxygen, hypoxia, causes blood vessels to dilate to try and get more blood flow, low oxygen in the lungs triggers the opposite response: vasoconstriction. The blood vessels in that specific low oxygen area clamp down. This protective physiological reflex, called hypoxic pulmonary vasoconstriction, HPV, actively shunts blood away from poorly oxygenated or collapsed areas of the lung. It redirects that blood flow to better ventilated areas where it can pick up oxygen more effectively. It's a remarkable evolutionary adaptation, ensuring efficient gas exchange even when parts of the lung aren't functioning optimally. It helps match ventilation with perfusion.
It's like the lungs are constantly trying to find the most efficient route for blood. But sometimes that delicate fluid balance can go wrong, leading to pulmonary edema.
Indeed, normally there's a fine balance of pressures in your lung capillaries. Forces that keep fluid inside the blood vessels, like plasma protein concentration, usually win out over forces that would push fluid out into the surrounding lung tissue, like blood pressure within the capillary. The lymphatic system also helps drain any excess fluid. But if this balance is disrupted, fluid can accumulate in the lung tissue, interstitial edema, or even directly in the air sacs, alveolar edema, leading to pulmonary edema. This accumulation of fluid severely disrupts gas exchange, making it much harder for oxygen to cross from the air sacs into the blood. Carbon dioxide exchange is less affected because CO2 is much more soluble.
What disrupts that balance?
Various things. Perhaps your heart isn't pumping effectively, like in heart failure, leading to increased pressure backing up into the lungs' blood vessels, causing fluid to leak out. That's cardiogenic edema. Or the tiny capillaries themselves become leaky due to inflammation or injury, as seen in severe infections like sepsis or from inhaling toxic fumes. That's non-cardiogenic edema or ARDS. Even certain brain injuries can trigger a cascade that leads to this fluid buildup in the lungs. When it happens, the lungs become heavy, stiff, and it's incredibly difficult to get enough oxygen.
Okay, let's unpack this. The hemoglobin in your blood is like a sophisticated taxi service for oxygen, picking it up in the lungs and dropping it off where it's needed in the tissues. But all sorts of things can affect its route and how efficiently it performs.
That's a perfect analogy. The vast majority of the oxygen your body uses, about 99%, isn't just dissolved in your blood plasma. There's very little dissolved oxygen. It's bound to hemoglobin, a protein packed inside your red blood cells. Each gram of hemoglobin can carry about 1.36 milliliters of oxygen. Without sufficient hemoglobin, your body simply couldn't transport enough oxygen to meet the demands of your tissues no matter how much you breathe in. Anemia, for example, severely impacts oxygen delivery.
And the way hemoglobin holds onto oxygen isn't constant.
Exactly. The relationship is shown by the oxyhemoglobin dissociation curve, which has a characteristic S shape. This curve illustrates hemoglobin's affinity, or stickiness, for oxygen at different oxygen levels. This affinity isn't static. It changes depending on the local environment. In your lungs, where oxygen is plentiful, hemoglobin has a high affinity, so it loads oxygen easily. It gets saturated quickly. But at your tissues, where oxygen levels are lower because cells are using it, hemoglobin's affinity decreases, allowing it to release that oxygen where it's needed.
And that change in affinity is influenced by the local conditions.
Precisely. This is where things get really clever. A right shift in this curve means hemoglobin lets go of oxygen more easily. Its affinity decreases. This happens when the tissues are metabolically active, higher temperature, higher carbon dioxide levels, and lower pH, more acidic. Think about a working muscle. It's warmer, producing CO2 and lactic acid. These conditions signal hemoglobin. Release oxygen here. This phenomenon, particularly the influence of CO2 and acidity, is known as the Bohr effect. Conversely, a left shift means hemoglobin holds onto oxygen more tightly. Its affinity increases. This happens in conditions like lower temperature, lower CO2, or higher pH, more alkaline, such as in the lungs, where you want hemoglobin to grab onto oxygen efficiently. Another factor is a molecule called 2-gal-3-DPG inside red blood cells, which also promotes oxygen release. Shifts right.
So the body fine-tunes oxygen release based on need, but some things can interfere badly.
Absolutely. Several conditions can severely disrupt oxygen transport. Take carbon monoxide, CO, poisoning. Carbon monoxide binds to the same spot on hemoglobin as oxygen, but over 200 times more tightly. It essentially hijacks your oxygen taxis. Not only does it prevent oxygen from binding, but the CO that does bind causes a significant left shift in the curve for the remaining oxygen sites. This means the hemoglobin holds on to any remaining oxygen much more tightly, preventing its release to the desperate tissues. What's particularly dangerous is that standard pulse oximeters, which measure oxygen saturation, can be misleadingly high because they detect hemoglobin saturation but can't distinguish between O2 and CO binding.
That's terrifying.
It is. Treatment involves removing the source and giving very high concentrations of oxygen, sometimes even hyperbaric oxygen, to try and displace the CO. Another condition is methemoglobinemia, where the iron in hemoglobin gets oxidized to a form, Fe3+, that simply cannot bind oxygen at all, often caused by certain medications or toxins. This also requires specific treatment, like methylene blue.
So calculating the actual oxygen content is important.
Very. For medical teams, understanding how much oxygen is truly in the blood is key. We calculate the arterial oxygen content, CaO2, which factors in hemoglobin levels, the percentage of hemoglobin saturated with oxygen, and the small amount dissolved in plasma. Normal is about 20 milliliters of O2 per 100 milliliters of blood. And we also look at the mixed venous oxygen content, CVO2, in blood returning from the tissues, normally about 15 mmol/dl. The difference between these, CaO2, CVO2, tells us how much oxygen your body is actually extracting and using. A larger difference might mean low heart output or high metabolic demand, while a smaller difference could suggest blood is bypassing tissues, like in severe sepsis.
And this helps understand problems like shunting.
Yes, exactly. Calculating these oxygen contents allows us to estimate the degree of pulmonary shunt, the fraction of blood flowing through the lungs that doesn't get oxygenated. We use something called the shunt equation. This raises an important question. Why is hypoxemia that doesn't improve with supplemental oxygen so concerning? Because it points to a significant shunt. If blood is flowing past completely collapsed or fluid-filled alveoli, it bypasses oxygenation entirely. Giving more oxygen helps the functioning parts of the lung saturate fully, but it can't reach the blood in the shunted areas. Normal lung regions are already near 100% saturation on room air or low oxygen, so they can't compensate much. This is different from a ventilation perfusion VQ mismatch, where the problem is just that air and blood aren't perfectly aligned in some areas. Often, these situations do improve with extra oxygen because you can boost the oxygen levels in the poorly ventilated but still perfused areas. Distinguishing between shunt and VQ mismatch is critical for diagnosis and treatment. So oxygen is the vital cargo, but what about carbon dioxide, the body's other critical cargo? How is that handled differently?
Carbon dioxide also transported in your blood, but primarily in a different way than oxygen. Only about 5–10% is physically dissolved in plasma, and another 5–10% binds directly to proteins in the blood, including hemoglobin-forming carbamino compounds. But the vast majority, about 80–90%, is transported as bicarbonate ions, HCO3. Here's how that works. Inside your red blood cells, CO2 rapidly combines with water, thanks to a very efficient enzyme called carbonic anhydrase, to form carbonic acid, H2CO3. This carbonic acid then quickly dissociates into a hydrogen ion, H+, and a bicarbonate ion, HCO3. The bicarbonate then moves out of the red blood cell into the plasma to be transported to the lungs. To maintain electrical neutrality when the negatively charged bicarbonate leaves, a negatively charged chloride ion moves into the red blood cell from the plasma. This is known as the chloride shift, or hamburger shift.
And how does oxygen affect this process?
This is where the Haldane effect comes in. It's the flip side of the Bohr effect we discussed for oxygen. The Haldane effect describes how the oxygenation state of hemoglobin influences CO2 transport. When hemoglobin is deoxygenated, like in the tissues after dropping off O2, it's actually a better carrier of CO2. It can bind more H+ ions, resulting from the carbonic acid dissociation, allowing more CO2 to be converted to and carried as bicarbonate. It also binds CO2 directly more readily. Conversely, when hemoglobin becomes oxygenated in the lungs, its affinity for CO2 decreases. It releases those H+ ions, which encourages bicarbonate to recombine with H+ to form carbonic acid, which then breaks down into CO2 and water. The CO2 then diffuses into the alveoli to be exhaled. If we connect this to the bigger picture, the Bohr and Haldane effects are two sides of the same coin, demonstrating a beautiful synergy where oxygen and carbon dioxide transport are intricately linked and mutually beneficial for efficient gas exchange at both the lungs and the tissues.
It's amazing biochemical choreography. And all of this gas exchange is intimately tied to the body's acid-base balance, or pH patrol. How does the respiratory system play into this?
The respiratory system is absolutely crucial for maintaining the body's normal pH balance, which ideally stays within a very narrow range around 7.4. It works in concert with your kidneys and chemical buffer systems in the blood. Why is pH so important? Even small changes can profoundly affect how your body's proteins and enzymes function, including things like how well hemoglobin binds oxygen. Your body's metabolism produces a tremendous amount of acid daily. Most of this comes from the CO2 produced, which, as we just saw, forms carbonic acid in the blood. Because this acid can be converted back into CO2 gas and simply exhaled by the lungs, it's called a volatile acid. Your lungs eliminate a truly astonishing amount of this potential acid every day, over 10,000 milliequivalents. In contrast, a much smaller amount of non-volatile or fixed acids, like lactic acid or keto acids, are produced from other metabolic processes, maybe 100 mg. These cannot be exhaled and are primarily removed by your kidneys. This difference is vital clinically. In situations of severe metabolic acidosis, Like after a prolonged cardiac arrest where lactic acid built up massively, your body's chemistry gets so out of whack that even life-saving medications like epinephrine might not bind to their receptors effectively until that pH balance is partially restored, often with intravenous bicarbonate.
So your breath is literally keeping your body's chemistry in check. This leads us to interpreting arterial blood gases, ABGs, often called the body's chemical report card.
An arterial blood gas, or ABG, is a common and vital blood test. It gives medical teams an immediate snapshot of several key parameters. Your blood pH, normal 7.35, 7.45, the partial pressure of carbon dioxide, PCO2, normal 35-45 millimeter Hg, the partial pressure of oxygen, PaO2, and your bicarbonate level, HCO3, normal 22-26 MEQL. From these numbers, we can identify four major primary acid-based disturbances. Respiratory acidosis. Too much CO2, high PaCO2 is retained, lowering the pH, metabolic acidosis. There's an excess of fixed acids or loss of bicarbonate, lowering the pH, respiratory alkalosis. Too much CO2 is blown off, low PaCO2, raising the pH, metabolic alkalosis. There's a loss of fixed acids or an excess of base, raising the pH. These can occur alone or in combination, and your body also has compensatory mechanisms that try to bring the pH back towards normal.
How do those compensations work?
The respiratory system can compensate very rapidly within minutes for metabolic problems. For example, if you have metabolic acidosis, perhaps from intense exercise producing lactic acid, or kidney failure, your respiratory system will immediately respond by increasing your breathing rate and depth, hyperventilation, to blow off more CO2. Getting rid of CO2 helps raise the pH back towards normal. Conversely, if you have metabolic alkalosis, your breathing might slow down slightly to retain CO2. Your kidneys compensate for respiratory problems, but much more slowly, over hours to days. If you have chronic respiratory acidosis from, say, severe COPD, where you can't blow off CO2 effectively, your kidneys will gradually retain more bicarbonate, HCO3, to buffer the acid and help normalize the pH. If you have chronic respiratory alkalosis, the kidneys will excrete more bicarbonate. Understanding these primary problems and the expected compensations helps medical teams diagnose the underlying issue and guide treatment. For example, if a patient on a ventilator has too much CO2, respiratory acidosis, the immediate solution is often just to adjust the ventilator settings to help them breathe more effectively. You wouldn't treat respiratory acidosis with bicarbonate, as that would just generate more CO2.
It's truly incredible how your body has these internal sensors, constantly tweaking your breathing rate and depth, making sure you get exactly the right amount of oxygen and CO2, even when you're completely unaware.
That's the brilliance of the chemical control of breathing. It's an automatic, involuntary process driven primarily by feedback loops. The main drivers for how fast and deep you breathe are the levels of carbon dioxide, specifically the resulting H+ ions or acidity in your arterial blood and, perhaps more importantly, in the cerebroclinal fluid, CSF, surrounding your brainstem. Interestingly, low oxygen levels, hypoxemia, actually potentiate your body's response to carbon dioxide. So for any given CO2 level, your drive to breathe becomes stronger if your oxygen levels are also low.
But medications can interfere with this.
Profoundly. Many medications, especially opioids, general anesthetics and sedatives, hypnotics, can significantly depress this crucial breathing response to CO2. This is a major consideration in anesthesia and pain management. Also, for patients with certain chronic lung conditions like severe COPD, their body's response to chronically high carbon dioxide might become blunted over time. In these individuals, their hypoxic drive, the drive to breathe stimulated by low arterial oxygen, PaO2, may become the dominant mechanism for maintaining spontaneous breathing. This is a critical clinical point because it means administering high concentrations of oxygen to these specific patients can sometimes paradoxically reduce their drive to breathe as it removes the main stimulus they were relying on.
Where are the sensors located?
Your body has two main types of chemical sensors, or chemoreceptors. The central chemoreceptors are located on the surface of the medulla in your brainstem. They don't directly sense blood CO2 because of the blood-brain barrier, but they are exquisitely sensitive to changes in the pH, the H+ concentration, of the surrounding CSF. Since CO2 crosses the blood-brain barrier easily and forms acid in the CSF, changes in blood PaCO2 rapidly affect CSF pH and stimulate these receptors. They are the major players, responsible for setting your resting breathing level and providing about 2/3 of the response to CO2 changes. They aren't directly stimulated by low oxygen. In fact, severe hypoxia might even suppress them. Then there are the peripheral chemoreceptors. These are small clusters of cells located primarily in the carotid bodies, at the branching of the carotid arteries in your neck, sending signals via the glossopharyngeal nerve. And the aortic bodies. in the arch of the aorta, signaling via the vagus nerve. The carotid bodies seem to have a greater influence. These peripheral sensors are strategically positioned to detect large decreases in arterial oxygen, PaO2. They also respond to increases in PaCO2 and decreases in arterial pH. If your oxygen levels plummet, these peripheral sensors send urgent signals to your brainstem to increase ventilation, raise blood pressure, and even cause some airway constriction. They contribute about 1/3 of the overall ventilatory response. It truly is a symphony of feedback loops, constantly monitoring and adjusting.
That brings us to our final section, when this finely tuned system goes wrong. Let's start with how something as common as general anesthesia affects respiratory physiology.
General anesthesia has a really profound impact on your respiratory system, affecting nearly every aspect we've discussed. One of the most significant and immediate changes is a decrease in your functional residual capacity, FRC, that gas reservoir in your lungs. This happens simply by changing from an upright to a lying down supine position, and it decreases even further when general anesthesia is induced and muscle relaxants are given. This loss of FRC contributes to small airway closure and the development of atelectasis, or the collapse of small areas of lung tissue, especially in the dependent parts of the lungs near the diaphragm. This is almost universal under general anesthesia, and is a primary reason why oxygen levels might drop slightly during or after surgery.
So the lungs just aren't as expanded. Does ventilation change too?
Yes. Positive pressure ventilation, commonly used during surgery, tends to distribute air differently than spontaneous breathing. It can sometimes lead to areas that are ventilated, but not well supplied with blood, increased dead space, or areas that are perfused but poorly ventilated, increased shunt, often due to atelectasis. This mismatch between ventilation and perfusion widens the difference between oxygen levels in the alveoli and the arteries. Anesthesia also changes the mechanics. Chest wall compliance actually increases. It becomes less stiff or more floppy, especially with muscle relaxants. However, airway resistance can increase, particularly due to the presence of a breathing tube or laryngoscopy stimulating reflexes. On the plus side, most inhaled anesthetics, except nitrous oxide, are actually bronchodilators, which can be beneficial for patients with asthma or COPD.
And the breathing drive itself.
Critically, all volatile anesthetics and most intravenous agents depress the body's natural breathing drive. The ventilatory response to increased CO2, low oxygen hypoxia, and metabolic acidosis is significantly blunted. This is why patients often need mechanical ventilation during general anesthesia and careful monitoring afterwards.
It seems like a lot of changes are happening to the system, making it more vulnerable. Now let's move to a very common condition. Obstructive sleep apnea, or OSA, when breathing stops during sleep.
OSA is a disorder characterized by repetitive episodes where your upper airway, the part behind your tongue and soft palate, partially or completely closes off during sleep. This blockage stops or significantly reduces airflow despite continued effort to breathe. These episodes lead to intermittent drops in blood oxygen levels, hypoxia, and brief awakenings, arousals that fragment sleep even if you don't remember waking up. Diagnosis is typically made with an overnight sleep study called polysomnography, which measures breathing, oxygen levels, brain waves, and other factors. The severity is often graded using the Apnea-Hypopnea Index, AHI, which counts the number of apneas, complete cessations, and hypopneas, partial reductions in airflow with oxygen drop or arousal per hour of sleep. An AHI above 5 with symptoms, or above 15 even without symptoms, is generally considered diagnostic.
And it's linked to many other health problems.
Absolutely. What's critical for understanding OSA is its widespread impact beyond just daytime sleepiness. It's strongly linked to numerous other serious health issues, including high blood pressure, especially treatment-resistant hypertension, congestive heart failure, coronary artery disease, irregular heart rhythms like atrial fibrillation, and an increased risk of stroke. It's also frequently associated with conditions like type 2 diabetes, metabolic syndrome, obesity, and even things like GERD, acid reflux, and glaucoma. It significantly increases risks during surgery and anesthesia as well.
That's a huge list of associated conditions. So how is OSA typically treated?
The gold standard treatment for moderate to severe OSA is continuous positive airway pressure, or CPAP. This involves wearing a mask over the nose or face during sleep that delivers a continuous stream of pressurized air. This positive pressure acts like an air splint to keep the upper airway physically open, preventing collapse. While highly effective, adherence can be a challenge for some people. Other treatments include lifestyle changes like weight loss, which is crucial for many obese patients and can sometimes even resolve OSA. There are also oral appliances designed to pull the lower jaw forward, opening the airway space. For some, surgical procedures to remove excess tissue in the throat might be an option. More recently, implantable devices that stimulate the nerve-controlling tongue movement, hypoglossal nerve stimulators, have become available for certain patients.
And how does this impact anesthesia? You mentioned increased risk.
Yes. This raises an important question. Why is a condition like sleep apnea, often seen as just a sleep disturbance, so critical for anesthesiologists to understand? Because it transforms what might otherwise be routine surgical procedures into potentially high-risk scenarios, demanding meticulous planning and vigilance. Patients with OSA are known to be more sensitive to sedatives and opioids, and they have a higher risk of airway obstruction, especially during induction of anesthesia and after surgery when they are recovering. Their airway anatomy might also make inserting a breathing tube more difficult. So for these patients, medical teams perform careful preoperative assessments, often encouraging patients to use their CPAP before and after surgery. They anticipate potential airway difficulties, often having specialized equipment like video laryngoscopes ready. They tend to use shorter-acting medications, minimize opioids, and ensure patients are fully awake with good airway reflexes before removing the breathing tube. Vigilant monitoring, especially for respiratory depression and obstruction, is crucial in the recovery period. Using regional anesthesia techniques that avoid airway manipulation is often preferred when possible.
That's a comprehensive approach showing how seriously it's taken. Now let's dive into chronic obstructive pulmonary disease, or COPD.
COPD is a common, preventable, and treatable lung disease characterized by persistent respiratory symptoms and airflow limitation that is usually progressive and not fully reversible. This limitation stems from airway and/or alveolar abnormalities, typically caused by significant exposure to noxious particles or gases. The primary cause, overwhelmingly in developed countries, is cigarette smoking, often requiring decades of exposure before symptoms manifest. However, other inhaled pollutants like biomass fuel smoke in poorly ventilated homes, occupational dusts, and genetic factors like alpha-1 antitrypsin deficiency can also cause or contribute to COPD.
And it involves both airway and lung tissue problems.
Yes, COPD typically involves a mixture of two main pathological processes, though the balance varies between individuals: chronic bronchitis and emphysema. Chronic bronchitis is defined clinically by a chronic productive cough for at least 3 months in each of 2 successive years. Pathologically, it involves inflammation and excessive mucus production in the larger airways, and inflammation and narrowing of the small airways, bronchioles. Emphysema, on the other hand, involves the destruction of the lung parenchyma, the gas-exchanging surfaces, alveoli, distal to the terminal bronchioles. This leads to permanent enlargement of these air spaces, a loss of surface area for gas exchange, and critically, a loss of the natural elastic recoil of the lungs that helps support small airways and push air out during exhalation. Think of it like a stretched-out, damaged sponge with fewer, larger holes. So the lungs lose their snap. Exactly. That loss of elastic recoil, combined with small airway inflammation and narrowing, leads to the characteristic airflow limitation, especially during exhalation. Air gets trapped in the lungs, leading to hyperinflation. This makes it harder to breathe in deeply and increases the work of breathing. Gas exchange becomes inefficient, leading to low oxygen levels, hypoxemia, and in advanced stages, high carbon dioxide levels, hypercapnia. Patients typically experience progressive shortness of breath, dyspnea, chronic cough, often productive, and wheezing. Diagnosis is confirmed with spirometry, a breathing test, showing persistent airflow limitation, specifically a reduced ratio of the air forced out in 1 second, FEV1, to the total air forced out, FVC, even after giving a bronchodilator.
So it's a grim progression, but how is it generally managed?
Unfortunately, no current treatment reverses the underlying lung damage in COPD. But quitting smoking is absolutely essential, as it's the only intervention proven to significantly slow the rate of lung function decline. Management focuses on relieving symptoms, improving exercise tolerance and quality of life, and preventing and treating exacerbations, flare-ups. This includes bronchodilator medications, beta agonists and anticholinergics, often long-acting and sometimes combined, to relax airway muscles and improve airflow. Inhaled corticosteroids may be added for patients with frequent exacerbations. Pulmonary rehabilitation programs, which include exercise training, education, and support, are highly effective and recommended for most patients with significant symptoms. Oxygen therapy is used for patients with severe resting hypoxemia. Vaccinations, influenza and pneumococcal, are important to prevent infections. In very select cases, surgical options like lung volume reduction surgery or lung transplantation might be considered.
And managing COPD patients during anesthesia requires special care too.
Definitely. Patients with COPD are at higher risk for postoperative respiratory complications, especially after thoracic or upper abdominal surgery. Preoperatively, the goal is to optimize their lung function, ensuring they're using their inhalers correctly, treating any active infection or inflammation, and clearing secretions. Spirometry isn't used to prohibit surgery, but it helps assess severity. Intraoperatively, regional anesthesia is often preferred if feasible to avoid airway manipulation and the effects of general anesthesia on lung mechanics. If general anesthesia is necessary, volatile anesthetics are often used for their bronchodilating effects. Humidifying the inhaled gases help keep secretions loose. Careful ventilation management is key.
Right, you mentioned PEEP earlier. How does that fit in with COPD ventilation?
Yes, ventilation strategy is critical. Because COPD patients have difficulty exhaling fully, they are prone to air trapping and developing autoPEEP, intrinsic PEEP, pressure building up in the alveoli at the end of exhalation. This increases the work of breathing and the risk of lung injury, barotrauma. To minimize this, ventilators are often set to allow longer expiratory times, e.g. a lower IE ratio. What's fascinating, and perhaps counterintuitive, is the role of adding external PEEP from the ventilator. While adding pressure might seem bad if the lungs are already hyperinflated, studies suggest that applying a low level of PEEP, typically set slightly below the patient's measured auto-PEEP level, can actually be beneficial. It may help stent open the small airways during exhalation, preventing them from collapsing completely. This can reduce the patient's effort needed to trigger the next breath by counteracting the auto-PEEP and potentially reduce injury from repeated opening and closing of airways without worsening hyperinflation if set carefully. It requires careful titration and monitoring.
Very interesting. Okay, next up, asthma, a chronic inflammatory airway disorder.
Asthma is defined as a chronic inflammatory disorder of the airways involving many cell types, especially mast cells, eosinophils, and T lymphocytes. In susceptible individuals, this inflammation causes recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or early in the morning. These symptoms are associated with widespread but variable airflow obstruction within the lungs that is often reversible, either spontaneously or with treatment. This chronic inflammation also causes an increase in airway hyperresponsiveness. The airways become twitchy and narrow excessively in response to various stimuli. This underlying inflammation and reversibility are key features that differentiate asthma from COPD, although some patients can have features of both. Asthma-COPD overlap syndrome.
What triggers these asthma symptoms?
The triggers can be diverse. Common ones include allergens like pollen, dust mites, animal dander, viral respiratory infections like colds, exercise, cold air, irritants like tobacco smoke, pollution, strong odors, certain medications like aspirin or beta blockers in some individuals, and even emotional stress. When someone with asthma is exposed to their trigger, it sets off an inflammatory cascade. Potent biochemical mediators are released, causing several things to happen rapidly. The smooth muscles surrounding the airways constrict, bronchoconstriction. The airway lining swells due to increased vascular permeability and edema, and mucus production increases, sometimes forming thick plugs. All these contribute to narrowing the airways and making it difficult to breathe.
So the airway basically overreacts.
Exactly. The airway becomes hyperresponsive. The severity of symptoms often parallels the degree of airflow obstruction. In severe, prolonged attacks, known as status asthmaticus, the obstruction can become refractory to standard bronchodilator therapy, leading to exhaustion, potential respiratory failure, and is considered a medical emergency. Sometimes potent drugs like ketamine or even inhaled anesthetics might be used in the ICU to treat it.
Given this potential for sudden, severe airway narrowing, how is anesthetic management handled for an asthmatic patient? Here's where it gets really interesting. Imagine your airways suddenly constricting, like trying to breathe through a straw. That's what a bronchospasm feels like, and knowing how to swiftly respond is paramount.
That's a very apt description of bronchospasm. For patients with asthma undergoing surgery, meticulous planning is key. The first step is a thorough preoperative evaluation, assessing the severity and control of their asthma. Are they having frequent symptoms, waking up at night, using their rescue inhaler often? Have they had a recent respiratory infection? If their asthma is poorly controlled, elective surgery might be postponed to allow time for treatment optimization, perhaps with a short course of oral steroids. Patients should continue their regular asthma medications and often receive a dose of their short-acting bronchodilator, like albuterol, shortly before anesthesia induction or airway manipulation. Anxiolytics might be used cautiously to reduce stress-induced bronchospasm.
What about anesthesia drugs themselves?
Anesthesiologists choose induction agents carefully. Propofol is generally well tolerated. Ketamine is unique as it has bronchodilating properties and might be preferred if the patient is actively wheezing or having emergency surgery. Barbiturates might be avoided. For maintenance, inhaled volatile anesthetics like sevoflurane, isoflurane, disflurane are generally good choices as they relax bronchial smooth muscle. Sevoflurane is often preferred for inhalation induction, especially in children, as the others can sometimes be airway irritants upon emergence. Certain muscle relaxants that release histamine, like atracurium, might be avoided. Similarly, histamine-releasing opioids like morphine might be used cautiously or avoided in favor of others like fentanyl. Beta blockers, if needed, require caution, with selective beta-1 blockers like esmolol being preferred. NSAIDs like ketorolac should generally be avoided in patients with known aspirin-exacerbated respiratory disease.
And if bronchospasm occurs during the procedure?
It's an urgent situation. The signs in an anesthetized patient include audible wheezing, increased airway pressures needed to ventilate, difficulty exhaling fully, seen on the capnograph waveform, and potentially falling oxygen levels. The immediate steps are: 1. Deepen the level of anesthesia, usually with a volatile agent or IV propylflucamidinodecaine. 2. Ensure 100% oxygen delivery. 3. Administer a rapid-acting inhaled beta-2 agonist, like albuterol, directly into the breathing circuit, often requiring multiple doses. 4. In severe cases, intravenous epinephrine might be given in small doses. 5. Intravenous corticosteroids, like hydrocortisone, are given, though their effect takes time. 6. Other agents like 5-E magnesium sulfate or even aminophylline might be considered in refractory cases. The goal is rapid reversal of the bronchoconstriction while differentiating it from other potential causes like an obstructed tube or anaphylaxis. Afterwards, ensuring a smooth emergence from anesthesia is important, often aiming for extubation when the patient is relatively deeply anesthetized or fully awake, depending on the situation, to minimize airway stimulation.
Shifting gears now, let's talk about pulmonary hypertension, or PH, and cor pulmonale, high pressure in the lung circulation.
Right. Pulmonary hypertension, pH, is defined as an elevated mean pulmonary artery pressure, PAP, typically measured as 25 millimeter Hg or higher at rest via right heart catheterization. The pulmonary circulation is normally a low-pressure, low-resistance system designed to handle the entire output of the heart with minimal effort from the right ventricle. In PH, however, the resistance in the pulmonary arteries increases significantly. This can be due to various causes, often grouped into categories. Pulmonary arterial hypertension, PAH, is a specific subgroup where the small pulmonary arteries themselves undergo structural changes, thickening, proliferation of cells leading to narrowing and increased stiffness. Other groups include PH due to left heart disease, PH is due to lung diseases, or chronic hypoxia like COPD, chronic blood clots in the lungs, CTEP, and other miscellaneous causes.
And this high pressure puts a strain on the heart.
Exactly. The right ventricle, RV, of the heart is not designed to pump against high resistance. When faced with persistently elevated pulmonary artery pressures, the RV has to work much harder. Initially, it compensates by thickening its walls, hypertrophy. But over time, this chronic pressure overload causes the RV to dilate, weaken, and eventually fail. This condition, right heart failure, occurring secondary to pulmonary pathology, is called cor pulmonale. COPD is a leading cause of cor pulmonale. The chronic low oxygen levels in COPD contribute to pulmonary vasoconstriction, further increasing the pressure the RV has to fight against.
This raises an important question. What happens when the delicate balance of pressure in your lungs goes awry? Pulmonary hypertension is a serious condition where the right side of the heart struggles immensely, impacting every breath.
It really does. Patients with PH often experience progressive symptoms like shortness of breath, especially with exertion, fatigue, chest pain, angina, dizziness, and fainting. Diagnosing it involves tests like echocardiography to estimate pressures and assess RV function, but the gold standard is a right heart catheterization to directly measure pressures and sometimes test the response to vasodilator drugs. Treatment aims to lower the pulmonary artery pressure and support the right ventricle. This often involves specialized medications that target pathways involved in pulmonary vasodilation, like prostacyclins, endothelin receptor antagonists, PDE5 inhibitors. Diuretics might be used to manage fluid overload from RV failure. Oxygen therapy is crucial for patients whose pH is driven by chronic hypoxia.
And anesthesia for these patients sounds very challenging.
Extremely challenging. The main goals are to avoid any further increases in pulmonary vascular resistance, PVR, and to maintain RV function and systemic blood pressure. Things that increase PVR must be rigorously avoided: hypoxia, hypercarbia, high CO2, acidosis, pain, stress, and hypothermia. Anesthetic drug choices are critical. Agents that significantly depress heart function or increase PVR, like potentially ketamine in some contexts or high doses of certain vasoconstrictors, are generally avoided. Etomidate is often favored for induction due to its hemodynamic stability. Opioid-based techniques with lower doses of volatile anesthetics might be used. Nitrous oxide is often avoided as it can slightly increase PVR and limits the ability to deliver high oxygen concentrations. Maintaining adequate systemic blood pressure is vital to ensure blood flow to the struggling right ventricle. Positive pressure ventilation needs careful management to avoid high airway pressures that could further impede RV function. Regional anesthesia might be an option, but large drops in systemic blood pressure from techniques like spinal anesthesia can be detrimental to RV perfusion. It requires meticulous monitoring and management.
Let's discuss pulmonary embolism, PE, a block in the blood flow.
A pulmonary embolism, or PE, occurs when an embolus, most commonly a blood clot, thrombus, lodges in the pulmonary artery or one of its branches, obstructing blood flow to a part of the lung. The vast majority of these thrombi originate in the deep veins of the legs or pelvis, a condition called deep venous thrombosis, DVT. The risk factors for DVT and subsequent PE are often summarized by Virchow's triad: venous stasis, slow blood flow, for example, from immobility or surgery; endothelial injury, damage to the vein wall; and hypercoagulability, an increased tendency for blood to clot, either inherited or acquired. Major surgery, especially orthopedic, trauma, cancer, prolonged immobility, pregnancy, estrogen therapy, obesity, and inherited clotting disorders are all significant risk factors. Less commonly, emboli can be composed of air, for example, from IV lines or surgical procedures; fat after long bone fractures; tumor cells; amniotic fluid; or foreign material.
So, what does this all mean for you? A pulmonary embolism is a stark reminder of the body's interconnected systems, where a clot formed far away, like in your leg, can travel and have sudden catastrophic consequences for your lungs and heart.
Precisely. When a PE lodges in the pulmonary vasculature, it has several immediate consequences. First, it blocks blood flow to the downstream lung tissue, creating alveolar dead space. That area is ventilated but not perfused, so it cannot participate in gas exchange. This leads to hypoxemia. Second, the obstruction increases the resistance in the pulmonary circulation, PVR, acutely increasing the workload on the right ventricle. If the embolus is large enough, a massive PE, this can lead to acute RV strain, dilation, and failure, causing hemodynamic collapse, shock, and even cardiac arrest. Third, mediators released from the clot and the affected lung tissue can cause further vasoconstriction and bronchoconstriction.
How does it typically present?
The presentation is highly variable, depending on the size and location of the embolus and the patient's underlying health. Small PEs might cause minimal symptoms or be asymptomatic. Larger PEs often cause sudden onset of unexplained dyspnea, shortness of breath, pleuritic chest pain, sharp pain worse with breathing, cough, sometimes with blood-streaked sputum, anxiety, and tachycardia, rapid heart rate. In massive PE, signs of RV failure like hypotension, JVD, jugular vein distension, and cyanosis occur. A very useful indicator, especially in anesthetized patients, is a sudden decrease or loss of end-tidal carbon dioxide, EtCO2, measured from their exhale breath. This happens because a large portion of the lung is being ventilated but not perfused, so less CO2 is returned to be exhaled. Diagnosis often involves clinical risk assessment tools like the Wells score, blood tests like D-dimer, sensitive but not specific. ECG may show signs of RV strain like S1Q3T3, echocardiography, and definitive imaging like a CT pulmonary angiography, CTPA, or a ventilation perfusion VQ scan.
And the
Treatment depends on the severity. For most PEs, the mainstay is anticoagulation, blood thinners, initially often with heparin, and then transitioning to oral anticoagulants to prevent new clots from forming and allow the body to dissolve the existing one. For patients with massive PE causing hemodynamic instability, more aggressive therapies like thrombolysis, clot-busting drugs, or even surgical or catheter-based embolectomy, removal of the clot, might be necessary. Supportive care, including oxygen and sometimes vasopressors to support blood pressure, is crucial. In some cases, an inferior vena cava, IVC filter, might be placed to physically trap clots traveling from the legs.
anesthesia management must be tricky.
Very. If a patient with a known or suspected PE requires surgery, the risks are high. The goals are to prevent further embolization, support respiratory function, often needing high FiO2, and maintain cardiovascular stability, especially RV function. Drugs that increase PVR, like ketamine or N2O, are generally avoided. Etomidate is often used for induction. Invasive monitoring, including potentially pulmonary artery catheterization, though risky itself, might be used to guide therapy. Postoperatively, these patients remain at high risk for complications like reperfusion injury when blood flow is restored to the previously blocked area.
Moving on to restrictive pulmonary diseases, where lung expansion itself is limited.
Right. Restrictive pulmonary diseases encompass a diverse group of conditions where the common feature is an inability of the lungs to fully expand during inspiration. This leads to reduced lung volumes, particularly the total lung capacity, TLC. Think of it as the lungs or the chest wall being too stiff or constricted. This restriction increases the elastic recoil, making the lungs want to snap back smaller and decreases overall compliance. Gas exchange can be impaired due to ventilation abnormalities, VQ mismatch, or diffusion problems. On pulmonary function tests, PFTs, the hallmark is a reduction of both the FEV1 and the FVC, but the ratio of FEV1 to FVC is typically normal or even elevated, distinguishing it from obstructive diseases where the ratio is low. What causes this restriction? The causes can be broadly categorized. Some affect the lung tissue itself, the interstitium. This includes conditions like interstitial lung diseases like idiopathic pulmonary fibrosis or asbestosis, where the tissue becomes scarred and stiff, or pulmonary edema, where fluid fills the interstitial space. Other causes are extrapulmonary, meaning they affect structures outside the lung parenchyma. Problems with the pleura, like thickening or scarring, fibrothorax, can encase the lung and prevent expansion. Issues with the thoracic cage itself, like severe kyphoscoliosis or chest trauma, flail chest, limit the space for the lungs. Significant obesity can restrict chest and diaphragm movement. And finally, neuromuscular diseases like muscular dystrophy or ALS that weaken the respiratory muscles also lead to a restrictive pattern because the bellows simply can't generate enough force to expand the lungs fully.
Let's revisit pulmonary edema specifically, looking at the different types.
Sure. As we touched on, pulmonary edema is fluid accumulation in the lungs, fundamentally caused by an imbalance in the Starling forces governing fluid movement across capillaries, either too much pressure pushing fluid out, hydrostatic, or the capillary walls becoming too leaky, increased permeability. Cardiogenic pulmonary edema is the high-pressure type, most often due to left-sided heart failure. The left ventricle isn't pumping effectively, so pressure backs up through the left atrium into the pulmonary veins and capillaries. When capillary pressure gets too high, say above 20-25 millimeter Hg, normally it's 10-16, fluid is forced out into the interstitium and eventually alveoli faster than the lymphatics can remove it. Non-cardiogenic pulmonary edema is the increased permeability type. Here, the primary problem isn't high pressure, but damage to the capillary endothelium itself, making it leaky. This allows not just fluid, but also protein to leak out, which further pulls fluid into the lung tissue. The most common cause is sepsis leading to ARDS, but it can also result from aspiration, toxin inhalation, pancreatitis, multiple transfusions, etc. Diagnostically, finding pulmonary edema on X-ray without evidence of high cardiac filling pressures, like a low pulmonary artery wedge pressure, points towards non-cardiogenic causes.
And the other types.
There's neurogenic pulmonary edema, which can occur after severe CNS insults like head trauma or seizures. It involves a massive sympathetic surge, causing both systemic and pulmonary vasoconstriction, overloading the heart and potentially increasing capillary permeability. And negative pressure pulmonary edema, also sometimes called post-obstructive pulmonary edema, can happen after vigorous attempts to inhale against a blocked airway, like biting down on a breathing tube or laryngospasm. The very negative pressure generated inside the chest can cause a sudden fluid shift into the lungs, sometimes exacerbated when the obstruction is relieved.
How do these patients typically present?
Regardless of the cause, the clinical picture involves increased work of breathing. Lungs become heavy, stiff, low compliance, and FRC decreases. Patients are usually tachypneic, breathing rapidly and shallowly, often driven by stimulation of receptors in the fluid-filled interstitium. They may use accessory muscles, show intercostal retractions. Sympathetic signs like high blood pressure, sweating, and tachycardia are common. Pink, frothy sputum is a classic, albeit late sign indicating alveolar flooding. Listening to the lungs often reveals crackles, rales, especially at the bases initially. Chest X-ray is key, showing characteristic patterns of fluid accumulation, which can sometimes help differentiate cardiogenic, often enlarged heart vascular redistribution, from non-cardiogenic types. ABGs invariably show hypoxemia due to shunting and VQ mismatch. CO2 levels might be low initially due to hyperventilation, but can rise later if the patient fatigues, which is a worrying sign. Treatment involves supporting oxygenation, often with PEEP, treating the underlying cause, and managing fluid balance, often diuretics for cardiogenic edema.
Next, a serious perioperative complication. Aspiration pneumonitis. Inhaling trouble.
Yes, aspiration pneumonitis specifically refers to the chemical injury caused when acidic or otherwise irritating gastric contents are inhaled into the lungs. It's distinct from aspiration pneumonia, which implies a subsequent bacterial infection. This chemical pneumonitis, sometimes called Mendelssohn syndrome, is a feared complication around the time of anesthesia. While relatively rare overall, maybe 1 in 3,000 general anesthetics, higher in emergencies or obstetric anesthesia, the consequences can be severe. It typically occurs when protective airway reflexes, coughing, gagging, are suppressed, most commonly during induction or emergence from anesthesia.
And why is it so feared? You mentioned the chemical burn aspect.
Exactly. This raises an important question. Why is aspiration so feared in anesthesia? Because it's a direct chemical burn to the lungs. Unlike a typical infection that might develop over time, the damage from aspirated stomach acid is immediate. The acid directly damages the lining of the airways and alveoli. This triggers a rapid and intense inflammatory response within hours. The lungs release inflammatory mediators, neutrophils rush in, capillaries become leaky, leading to pulmonary edema and hemorrhage, and surfactant, which keeps alveoli open, can be inactivated. This leads to atelectasis, severe VQ mismatch, shunting, and profound hypoxemia. While certain volume and pH thresholds like 0.4 millilg and pH 2.5 were historically cited as high risk, it's now recognized that many healthy fasting individuals meet these criteria without aspirating, and the risk is more complex, related to patient factors, obesity, diabetes, reflux, difficult airway, and the nature of the aspirin.
What are the signs and how's it managed?
Often, the first and most prominent sign is unexplained arterial hypoxemia. Other signs include tachypnea, dyspnea, wheezing or crackles, cough, tachycardia, and sometimes cyanosis or hypotension. Diagnosis can be difficult unless the event was witnessed or gastric contents are seen in the airway. Chest X-ray findings, infiltrates, often independent lung regions, may lag behind the clinical signs. Immediate management, if aspiration occurs, involves tilting the patient head down or to the side, rapidly suctioning the oropharynx, and securing the airway with intubation. Suctioning the trachea might be done, especially if particulate matter is suspected, though its benefit for liquid acid is debated. Bronchoscopy might be needed for solid material. Treatment thereafter is primarily supportive. Supplemental oxygen, mechanical ventilation with PEEP to help keep alveoli open and improve oxygenation, and careful fluid management. Steroids are controversial and generally not recommended routinely. Importantly, prophylactic antibiotics are not recommended unless there's evidence of subsequent infection, EDEMA fever persisting 48 hours, change in sputum, or aspiration of contaminated material like feces. Most initial aspirates are sterile, and unnecessary antibiotics promote resistance.
Let's discuss acute respiratory distress syndrome, or ARDS, a severe form of lung injury.
Acute respiratory distress syndrome, or ARDS, represents a severe diffuse inflammatory lung injury characterized by the acute onset of hypoxemia and bilateral infiltrates on chest X-ray, which are not fully explained by heart failure or fluid overload. It typically develops within a week of a known clinical insult and requires mechanical ventilation with at least some positive end expiratory pressure, peak equals 5 cm H2O. The term acute lung injury, ALI, is no longer used. ARDS now encompasses a spectrum of severity based on the degree of hypoxemia. The most common triggers leading to ARDS are sepsis, severe bacterial pneumonia, major trauma, and aspiration pneumonitis. But many other conditions can precipitate it, including pancreatitis, multiple transfusions, trachea form of ARDS, drug reactions, inhalation injuries, and shock states.
What's happening in the lungs during ARDS?
ARDS involves widespread damage to the alveolar capillary membrane, the delicate barrier where gas exchange occurs. The initial insult triggers a massive inflammatory cascade. Immune cells like neutrophils and macrophages become activated and release a flood of inflammatory mediators, cytokines like IL-8, TNF-alpha. These mediators cause increased capillary permeability, leading to leakage of protein-rich fluid into the interstitial space and alveoli, non-cardiogenic pulmonary edema. Surfactant production and function are impaired, contributing to alveolar collapse, atelectasis. The lungs become stiff, heavy, and poorly compliant. Microthrombi can form in the pulmonary vasculature, and PVR often increases. This results in severe VQ mismatch, large intrapulmonary shunts, and profound hypoxemia that is often refractory to high concentrations of oxygen alone.
How is ARDS managed?
Management is primarily supportive, focusing on treating the underlying cause and protecting the lungs from further injury while they heal. The cornerstone is lung protective mechanical ventilation. This involves using low tidal volumes, typically 6 millilocograms of predicted body weight, not actual weight, to avoid overstretching and injuring the less affected lung regions, follow trauma. It also involves keeping plateau pressures, a measure of pressure in the alveoli at the end of inspiration, below 30 cm H2O to limit pressure-related injury, barotrauma. PEEP is used often at higher levels than usual to help recruit or reopen collapsed alveoli and improve oxygenation, allowing for a reduction in FiO2. Sometimes permissive hypercapnia, allowing CO2 levels to rise slightly, is accepted to prioritize lung protection over strict CO2 control. Other strategies like prone positioning, lying the patient on their stomach, can significantly improve oxygenation in some patients. Careful fluid management is also crucial to avoid worsening edema.
Now, a specific transfusion complication. TRLI.
Yes, transfusion-related acute lung injury, or TRILI, is now recognized as the leading cause of transfusion-related fatalities. It's defined as new-onset acute lung injury occurring during or within 6 hours of blood product transfusion in a patient without other risk factors for Ailyards. Key features are acute hypoxemia, PaO2.FaO2 ratio 300, and bilateral infiltrates on chest X-ray, without evidence of circulatory overload, which would suggest TACO instead. While it clinically resembles ALEOS, TRILI often has a better prognosis, with many patients recovering within 96 hours, although it can still be fatal, 5–10%.
What's thought to cause it? You mentioned immune interactions.
What's fascinating here is how something meant to save lives. A blood transfusion can, in rare cases, trigger a profound inflammatory response in the lungs, highlighting the incredible complexity of the immune system. The most accepted mechanism involves antibodies present in the donor's plasma, often from multiparous women who develop antibodies to white blood cell antigens during pregnancy, reacting with the recipient's white blood cells, neutrophils. This interaction activates the neutrophils, causing them to aggregate in the pulmonary capillaries and release damaging substances that increase vascular permeability. There's also evidence for a two-hit model, where the recipient might have some underlying condition making their lungs susceptible, first hit, and then biologically active substances like lipids that accumulate in stored blood products provide the second hit, triggering the injury even without antibodies. Platelet transfusions seem to carry the highest risk.
How is it recognized and treated?
Patients typically develop sudden onset of dyspnea, hypoxemia, fever, chills, and sometimes hypotension or hypertension during or shortly after a transfusion. Chest X-ray shows bilateral fluffy infiltrates. Differentiating it from TACO, transfusion-associated circulatory overload, is crucial. TACO involves signs of fluid overload, like elevated JVP, S3 gallop, response to diuretics, while TRILI does not. Treatment involves immediately stopping the transfusion and providing supportive care, very similar to ARDS management. Oxygen mechanical ventilation with lung protective strategies if needed. Unlike TACO, diuretics are generally not indicated and could worsen hypotension if present. Reporting suspected cases is important for blood bank surveillance and donor management, for example, deferring donors implicated in trachea reactions.
And some medications themselves can actually cause lung disease.
Yes, it's a significant issue. Drug-induced pulmonary disease. Hundreds of different drugs have been implicated in causing various forms of lung injury, affecting hundreds of thousands of people annually. The mechanisms vary widely. Some drugs, particularly cytotoxic chemotherapy agents like bleomycin, can cause direct toxicity to lung cells or trigger inflammation and fibrosis. Other non-cytotoxic drugs can also cause problems through different pathways, often immunologic or by disrupting pulmonary homeostasis. A classic example is amiodarone, an antiarrhythmic drug. It can cause several patterns of lung toxicity in 5–50% of patients, including chronic interstitial pneumonitis, inflammation and scarring, organized pneumonia, ARDS-like reactions, or even solitary masses. The onset can be insidious with cough and dyspnea, or sometimes rapid and severe. Toxicity seems dose-related and requires stopping the drug and often corticosteroids, but resolution can be very slow due to amidarone's long half-life. Other patterns of drug-induced lung disease include hypersensitivity reactions, often with fever and eosinophilia, non-cardiogenic pulmonary edema, and diffuse alveolar hemorrhage. Anesthesiologists need to be aware of these possibilities when caring for patients on potentially toxic medications, sometimes adjusting oxygen therapy or fluid management accordingly.
Who knew that the very thing that sustains life oxygen could also be a silent toxin in high concentrations, leading to irreversible lung damage? It's a delicate balance.
It truly is. Pulmonary oxygen toxicity is a real concern, particularly with prolonged exposure to high concentrations of supplemental oxygen, FiO2, generally considered potentially toxic if 50–60% is used for more than 24–48 hours. The risk is related to both the partial pressure of oxygen and the duration of exposure. The problem stems from the excessive production of reactive oxygen species, free radicals like superoxide anion, hydrogen peroxide, when breathing high oxygen levels. These highly reactive molecules can overwhelm the body's natural antioxidant defense systems and damage cellular components like lipids, proteins, and DNA, particularly affecting the lung endothelium and epithelium. Clinically, early effects can include tracheobronchitis, airway inflammation causing substernal chest pain, especially on inspiration and cough.
Prolonged exposure can lead to an ARDS-like picture with diffuse alveolar damage, decreased lung compliance, impaired gas exchange, and absorption atelectasis, where high O2 concentrations wash out nitrogen, leading to alveolar collapse in poorly ventilated areas. The goal in clinical practice is always to use the lowest possible FiO2 that achieves adequate tissue oxygenation, usually targeting a specific SpO2 or PO2 goal. Using strategies like PEEP can often help maintain oxygenation while allowing the FiO2 to be reduced to safer levels.
Let's briefly touch on autoimmune disorders affecting the lungs.
Yes, many systemic autoimmune diseases conditions where the immune system attacks the body's own tissues, like connective tissue diseases or rheumatologic disorders, can frequently involve the lungs. For example, diseases like progressive systemic sclerosis, scleroderma, polymyositis dermatomyositis, rheumatoid arthritis, lupus, and Sjogren's syndrome can all have specific pulmonary manifestations. These can include interstitial fibrosis, scarring, pulmonary vascular disease leading to PH, inflammation of the small airways, bronchiolitis, pleural disease, or even weakness of respiratory muscles leading to aspiration or hypoventilation. Sarcoidosis is another important example. It's a multi-system granulomatous disorder of unknown cause, strongly influenced by genetics. It most commonly affects the lungs and lymph nodes within the chest. Non-case-eating granulomas, collections of inflammatory cells, form in the affected tissues. In the lungs, this typically occurs along lymphatic pathways and can lead to decreased lung compliance, impaired diffusing capacity, and reduced lung volumes, a restrictive pattern, although airway obstruction can also occur. Pulmonary hypertension and cor pulmonale can develop in advanced fibrotic stages. While many cases resolve spontaneously, it can cause significant chronic lung disease.
Finally, let's look at chest wall deformities and trauma, which can profoundly impact breathing mechanics.
Indeed, the structure and integrity of the chest wall are crucial for effective ventilation. Congenital deformities like pectus excavatum, funnel chest where the sternum is sunken, and pectus carinatum, pigeon chest where the sternum protrudes, are relatively common. While often primarily cosmetic concerns, severe cases can restrict cardiac or pulmonary function, reducing lung volumes and exercise tolerance. Surgical correction is sometimes performed. Acquired deformities like kyphoscoliosis, abnormal curvature of the spine in both posterior and lateral directions, can significantly distort the thoracic cage. If the curvature is severe, typically 60-70 degrees, it leads to a restrictive lung defect, reduced lung volumes, VQ mismatch, and eventually hypoxemia, hypercapnia, pulmonary hypertension, and cor pulmonale. Anesthetic management for surgical correction, for example spinal fusion, is complex due to the underlying respiratory compromise.
And acute trauma.
Acute chest trauma can cause life-threatening respiratory problems. A flail chest occurs when several adjacent ribs are fractured in multiple places, creating a segment of the chest wall that is no longer continuous with the rest of the rib cage. The hallmark is paradoxic movement. The flail segment moves inward during inspiration, when the rest of the chest expands, and outward during expiration. This impairs ventilation efficiency, increases the work of breathing, causes pain, and often leads to underlying lung confusion, bruising. Management involves aggressive pain control, like epidural analgesia or nerve blocks, and often requires mechanical ventilation with PEEP to stabilize the chest wall internally and support gas exchange. Pneumothorax, air in the pleural space, and hemothorax, blood in the pleural space, are also common after trauma, or sometimes occur atrogenically after central line insertion. A simple pneumothorax might just need observation or drainage. A communicating pneumothorax, sucking chest wound, requires an occlusive dressing.
And the most dangerous kind.
The most immediately life-threatening is a tension pneumothorax. This raises an important question. Why is a tension pneumothorax considered such a dire medical emergency? Because it's not just a collapsed lung. It's a rapidly escalating pressure cooker inside the chest that can fatally compromise circulation. Air leaks into the pleural space, often from an injured lung, but cannot escape, acting like a one-way valve. Pressure builds rapidly, collapsing the lung on that side and, critically, pushing the mediastinum, heart and great vessels, towards the opposite side. This compresses the contralateral lung and, crucially, kinks the vena cava, severely obstructing venous return to the heart. This causes a precipitous drop in cardiac output, profound hypotension, and severe hypoxemia. The clinical signs include respiratory distress, absent breath sounds on the affected side, tracheal deviation away from the affected side, distended neck veins, hypotension, and tachycardia. Immediate treatment is life-saving. Needle decompression in the second intercostal space midclavicular line or fifth intercostal space anterior axillary line, followed by definitive chest tube insertion.
Lastly, the very common issue of atelectasis. Here's where it gets really interesting. Even during a routine surgery, simply lying still and being under anesthesia can cause parts of your lungs to collapse. It's a testament to the body's constant need for movement and deep breaths to stay fully expanded.
Absolutely. Atelectasis, the collapse of previously inflated lung tissue, is incredibly common, especially under general anesthesia. It typically develops within minutes of induction, particularly in the dependent lung regions near the diaphragm. Several factors contribute. Anesthesia reduces muscle tone, including the diaphragm, changing chest wall mechanics. Supine position allows abdominal contents to push upwards. Breathing high oxygen concentrations can lead to absorption atelectasis in poorly ventilated areas. Positive pressure ventilation itself can lead to preferential ventilation of non-dependent regions, allowing dependent areas to collapse. While often minor and resolving spontaneously after surgery as the patient wakes up, moves, and takes deep breaths, atelectasis is the most common cause of postoperative hypoxemia and contributes to VQ mismatch. Strategies to prevent or treat it include using PEEP during anesthesia, performing recruitment maneuvers, briefly applying higher pressure to reopen collapsed alveoli, encouraging deep breathing and mobilization postoperatively, and potentially using specialized ventilation modes designed to maintain lung volume.
What an incredible journey through the breath of life. We've moved from the simple, often unconscious act of breathing to the intricate anatomy of its pathways, the delicate dance of gas exchange, and the constant chemical control that keeps everything in balance. And then we delved into what happens when this magnificent system faces challenges, from the impact of general anesthesia to obstructive sleep apnea, COPD, asthma, pulmonary hypertension, and acute conditions like pulmonary embolism, aspiration pneumonitis, ARDS, and even the surprising dangers of oxygen toxicity. It's clear how interconnected all these aspects are, each nuance playing a vital role in our overall health and survival. We hope this deep dive has empowered you with a more profound appreciation for every single breath you take and the incredible resilience and sometimes vulnerability of the human body. Think of these nuggets of knowledge as building blocks, offering you a shortcut perhaps to being truly well informed about the complex miracle happening within you right now.
This raises an important question. Given the sheer complexity and delicate balance of the respiratory system that we've explored, how might our increasing understanding of its intricate mechanisms, things like HPV, surfactant function, inflammatory pathways, continue to revolutionize critical care and preventative medicine in the coming decades?
And perhaps how might this newfound appreciation for the breath of life change the way we approach our own well-being day to day, knowing the constant, vital miracle happening within us with every inhale and exhale? Something to think about. Thanks for joining us on The Deep Dive.